Thank you enormously for the opportunity to talk to all of you today. And I must say that it's with great regret that I can't be there in person, but I certainly hope that over the next few months we can get to talk about some of the issues that are raised. I hope to talk about the importance of addressing prevention science. And while many of you certainly understand the critical role of it, I hope to raise a couple of additional issues. Let me start off by saying that we first completed considerable work through a commission that involved Dean Freed and many others across the nation that highlighted the lack of support for prevention science. I then look at some of the data, which is based upon some new reports that we've published, highlighting how little money is actually spent on prevention science, including public health research, before talking to the importance of expanding the scope and starting to look at the benefits of prevention science that go beyond purely producing the evidence before a call to action. Let me start off by talking about the Vitality Institute Commission. We recognized when we started the Vitality Institute, which is part of Discovery Holdings worldwide, that to succeed in getting the message around prevention out, one needed to have a greater focus of people understanding the value of prevention in public policy. And that in the US, the historical dominance, particularly of medicine in the field of health, had actually meant that we've had far less investment in public policy related to prevention than we have in treatment and cure. A critical reason why America's healthcare costs so much and achieves relatively less than many European countries was highlighted by Elizabeth Bradley in her recent book on the American Paradox. In it, she draws attention to the fact that while the rest of the world, particularly Europe, spends an enormously larger amount on preventive and social services, the US spends that money more on healthcare and treatment, the consequence being that for the same amount of investment, substantially better outcomes are obtained in the European environment than in the US. With that in mind, we actually established a commission to look into deeper origins and reasons for the neglect of prevention in the US. And you can see on the screen many of the notable people who were involved. Very importantly, it was led by Will Rosenzweig, who is an entrepreneur and really brought us a range of healthy foods, focuses on health devices, not somebody who comes from the traditional field of public health, but somebody who's passionate about health itself. In addition, you'll see many people who come from the public sector, the private sector, from the NGO world, and from inside President Obama's task force on prevention, Jeff Levy, for example. And as I said, I think they bring wisdom from across many different sectors. Their key recommendations really focused on the question of why is it that we're not seeing a better focus on health in the country. The first recommendation is the one I'll go into in a bit more detail, and that is the need to invest in prevention science. The others are worthwhile taking up at some other point in time. And I'd particularly draw your attention to recommendation 3, which focuses on how can we make markets work for health. In all of my training in public health, and I hate to think that it was 30 years ago that I graduated from Johns Hopkins, we really spoke about the private sector role and the power of markets as a force for good in health. I think we're starting to see through many recent examples that if we do harness that, it'll be able to complement the often meager resources of the public sector. So let me turn to what we've been finding. We carried out a large research project reviewing the grants of the National Institutes of Health over a 3-year period and reviewed well over 7,500 grants to try and look at how close was the real figure on prevention science investment compared to the official NIH figure that often gets used, where basically the statement is that about 20% of the total annual budget is spent on prevention. Through a meticulous process that I won't go into here, we showed that maybe about 7 to 9% was spent on human behavioral interventions, and of that, about a third was spent on primary prevention, meaning that maybe about 2% of the total $30 billion is truly spent on primary prevention. That, we believe, could start explaining why it is that we're seeing so little investment in the knowledge required to address the major burden of disease in this country. And if you look in more detail, you'll see that when the behavioral science component was examined in detail, a very small proportion was spent in a number of settings where health is truly created or maintained, including the school environment and the workplace. Once one looks at the data, we're really left with two, what I would say are contrasting views of the role of science and R&D in the US. The first, I think, is well epitomized by Francis Collins's recent statement, where he's very excited about the opportunities arising through breakthrough science, the opportunities of personalized medicine, the opportunities of applying genomic information, of actually starting to make breakthroughs in the brain, compared to what may be a little bit more of a mundane, boring approach that I stress, where one of the comments we make is that the current justification for the NIH funding based on breakthrough cures undermines the more significant funding opportunities for research to address sustained health gains and reduce disparities. Rarely is that seen as a goal of the NIH. And yet, without addressing it, I doubt that we actually are going to see the longevity and quality of life improvements that we're seeing across Europe. Nor do I believe we will close the gap in the enormous disparities that we have by counties in terms of life expectancy, which can be as much as 10 and 15 years from Marin County to many parts of Tennessee and Mississippi. Let me complement the comments about the National Institutes of Health by looking more broadly across the US at who spends on science more broadly. And I think an interesting figure emerges. We often think of the role of the pharmaceutical industry, the biomedical industry, as being dominant in spending in research. And of course, they do spend a large amount. But I think what we're starting to see is a shift, not away from, but a complement to pharmaceutical expenditure to computers, electronics, software, food and beverage, and maybe even in time, insurance. It's actually those groups who are now spending at huge levels. So if you look at your screen, you'll see that there's a group of neglected new partners emerging. I don't think people are aware of the fact that the private sector companies, particularly the software companies, are spending $14 billion annually on health-related digitally enabling technologies. $14 billion, that's almost half the size of the NIH. I also rarely hear my colleagues in health, particularly in public health, consider the role of Qualcomm or IBM or Microsoft or Samsung or Apple or Intel as actually leading a prevention revolution in health, and certainly they are. Just the recent announcements about the Apple Watch, the way Microsoft is starting to address sensors to promote longevity, quality of life. The support that Samsung and Intel has been giving to this for many years is proof of it. I was recently at the mHealth Summit when I was struck by the fact that the Qualcomm head gave a major talk on dementia. Qualcomm, a great software provider, recognizing that long-term issues of dementia are going to be fundamental to their business, and they have the means of solving it. I mention that because these are neglected opportunities for engagement between traditional public health research and what is some of the most fast emerging areas of science and technology that could really transform our lives. Let me also comment that when we think about the value of NIH investments, we often think of it purely in terms of the knowledge created, which itself, of course, is very important. But let's also remember that NIH funding supports indirect costs and can approach a large proportion of a budget. In fact, almost $750 million is used to support training and career development grants just in 2012, and most of those go to the winners of grants, which would be mainly in the clinical and laboratory sciences. I mention this because the scientists and the students who come out of a program that are supported by the NIH go on to be the leaders in their field. That, in my mind, explains why we don't have enough vigorous leadership coming out of public health and prevention science, because simply the number and the volume of leaders is not happening relative to the clinical and laboratory sciences. Another further interesting development that really is coming fast on the heels of the emergence of some of the new technology players has been even the need to rethink the way we go about assessing whether new technologies improve or don't improve health, or their benefits. We have been trapped in an era of doing most of the studies required to get FDA approval, usually through a randomized controlled trial. Well, I found it interesting in the recent JAMA that stealth research is being spoken about, where the enormous amount of biomedical innovation that's happening outside of the pharmaceutical industry usually, that may be happening well outside the traditional medical device area, but does involve software and computers, is driven often by a motive to develop new products and services with an entrepreneurial excitement, but may have enormously profound implications for health. For many of these entrepreneurs, waiting for an RCT is simply not what's going to happen. And it raises fundamental questions about how do we adapt our ability to know what is truly having a beneficial impact on health, and as importantly, potentially having a harmful impact on health that is done at a pace that keeps going in the same pace that the massive speed is happening in the technology world. One of the concerns coming out of many of these new technology areas relates to patient as well as doctor concerns around privacy. We are moving into a world of the Internet of Things, enormous connectivity. Enormous connectivity is going to bring spectacular gains for all of us. I have no doubt about that. But it's also bringing fears. People worry about their data. How secure is it? How well are we starting to worry about the interface that technology is having with people, both on the side of robotics, in terms of conversations with computers that are starting to have both positive and for some negative effects? How far have we gone in terms of preempting the social implications of new personalized devices, whether it's wearables, whether it's some of these new connected devices? For that reason, we believe in the Vitality Institute that we need to make sure that, in the words of David Satcher many years ago, our ethics is as good as our science. And to do that, we need to start building guidelines that take in the ethical, social, and legal issues in advance of them being over-regulated by a group of zealous regulators who may cut off the potential gains for public health that I believe are going to come through this massive advance in science and technology. The schools of public health need to be on the cutting edge of this debate, as they have been on so many other debates. Let me turn to a few recommendations, and first sum up by saying that I think this is perhaps one of the most exciting times in public health if we're able to bridge the divide between two things. One is seeing that the domain of public health as being purely that of the public sector, as opposed to opening ourselves to the new players that are coming out of the worlds of technology, from robotics, from artificial intelligence, from the worlds of software, and engaging them in positive ways. And secondly, if we're able to ensure that our ethical issues and principles get ahead of and anticipate what could be downsides or fears in the way we did that with the Human Genome Project and the creation of the ELSI initiative through the NIH. So a few recommendations. Clearly, I would hope we see increased and more targeted research on prevention of NCDs, particularly in community settings. And on this slide, there's a wonderful editorial by Darwin Labath that highlights just one of these large-scale community studies to address cardiovascular disease risks in Maine, which I found interesting because it was not funded by the NIH. Yet in many ways, it was a mirror of the kind of work we saw in Finland 30, 40 years ago that led to our greater understanding about what works for mass-based prevention of cardiovascular disease. Secondly, the National Institutes of Health Office of Prevention has been created by Francis Collins, and that is to be welcomed. The problem, though, is that it hasn't yet been adequately financed and doesn't have the resources to have the teeth required really to redress some of the enormous neglects that we've seen. Thirdly, I'd say that the NIH Foundation has done very well to create private-public partnerships in research focused on malaria, on some aspects of HIV/AIDS and the vaccine development. Now we need them to be far more aggressive in focusing on the opportunities for partnership with Qualcomm, IBM, Microsoft, Samsung, to build new notions of prevention for the public sector. I mentioned the critical need for a framework on ethical, social, and legal issues, and let me end off by saying that your voice, the voice of deans, will certainly be critical to the emerging debates on the value, scope, and direction in science, as it was almost 100 years ago. And I put this up to remind us of two interesting anniversaries. One is that over 100 years ago, a report on the national vitality of the people of America was supported by Theodore Roosevelt, led to some of the largest scale interventions around promoting longevity and quality of life. Much of that work included addressing primary prevention, addressing secondary prevention in the home, because people thought that Americans could do better than living on average to 45 years, which was the average at the time. And they could push it beyond that by another 15 years by focusing on prevention. That was 100 years ago. The tragedy was that many of our colleagues in the medical profession brought court cases against those trying to actually bring about those changes, and basically made the case that only medical doctors may get involved in the screening of people for early conditions, and then ultimately, of course, controlled and led to the ending of the entire program of longevity promotion that was supported by insurers. I mention that because I think we are at the start of starting to reinvent the kind of relationships we may see between public health and those involved even in life insurance and long-term insurance, because it's material to their business bottom line to make sure that people live longer and healthier lives. It reduces their costs, but it also improves the quality of life of Americans, which is exactly the vision of why Hopkins was created almost 100 years ago today. Thank you.